The webinar will begin at the top of the hour.
Good afternoon, everyone. Welcome to TAKEheart Module 2, Systems Change, Laying the Foundation, Leadership and Action Plan. My name is Teresa Rada. I'm an associate with Apt Associates, and I will be your moderator for today's discussion. This slide contains the disclosure and CEU information. Before we begin our presentation for today, we will start with a brief summary of the information presented in the first module. Module 1 created the case for cardiac rehabilitation with automatic referral and care coordination, and provided the scientific evidence to support implementation. Resources and references can be found in the Module 1 materials. Today's presentation is the second in a series of 10 webinars designed to provide support and share best practices with you about implementing automatic referral with care coordination in a cardiac rehabilitation program. The purpose of Module 2 is to support interested hospitals in building the foundation to support this change. This module will describe the role of the cardiac rehabilitation champion, guide the formation of the cardiac rehabilitation quality improvement team, and provide you with a framework for developing an action plan. We want to remind you to bookmark the TAKEheart website. This is the one stop for all TAKEheart educational materials and resources including training webinar recordings. Million Hearts 2022 is a national initiative to prevent 1 million heart attacks and strokes within 5 years. It focuses on implementing a small set of evidence-based priorities and targets that can improve cardiovascular health for all. The initiative seeks to keep people healthy, optimize care, and improve outcomes for priority populations. One goal set within Million Hearts was to create a roadmap to increase the use of cardiac rehabilitation to 70% of eligible patients. One of the resources you will find on the TAKEheart website under the Resource Center tab is the Cardiac Rehabilitation Change Package, CRCP. You will hear it referenced several times today because it serves as the roadmap for all of our training modules. The CRCP was created through a collaboration between the CDC and the American Association of Cardiovascular and Pulmonary Rehabilitation. The package includes evidence-based strategies, case studies, and 100+ tools and resources from 18 states, 22 institutions, and 36 cardiac rehabilitation professionals and researchers, just like yourselves, all aimed towards increasing participation in cardiac rehabilitation for and with eligible patients. As part of TAKEheart and using the CRCP developed by Million Hearts and the AACVPR, partner hospitals will implement a quality improvement program to adopt 2 evidence-based practices for increasing referral and enrollment: automatic referral of patients and care coordination. Our speakers today, Kim Newland and Kate Trainer, were actively engaged in the development of the Million Hearts Cardiac Rehabilitation Change Package. Both speakers are leaders in cardiac rehabilitation and have implemented automatic referral to cardiac rehabilitation. Kim is the Director of Cardiovascular Services at Sutter Roseville Medical Center and President of the Preventive Cardiovascular Nurse Association's Board of Directors. Since Kim assumed a leadership position in cardiac and pulmonary rehab 4 years ago, both programs have doubled in size and continue to grow. She also works on process improvement programs for the cardiovascular service line within the hospital and throughout the region. Kathleen Trainer is the immediate past president of the American Association of Cardiovascular and Pulmonary Rehabilitation and has received numerous awards for her work with cardiovascular prevention and rehabilitation. She has served as Director of Cardiovascular Disease Prevention at Massachusetts General Hospital since 1992, where her responsibilities include overall clinical, fiscal, and administrative management of 4 clinical programs and center personnel in the Heart Attack Prevention Program, Cardiac Rehabilitation Program, Metabolic Syndrome Program, Learn to be Lean Program, and the Women's Heart Health Program. These are our learning goals for today's webinar. We will explore what factors to take into account when selecting a cardiac rehabilitation champion, who will advocate for automatic referral with care coordination in your hospital and be a team leader. What qualities do you need in that champion? We will discuss who you may want to include when developing your cardiac rehabilitation implementation team and why. We will also offer you a framework and a template for creating an action plan to implement automatic referral with care coordination. Finally, we will conclude with a preview of the topics in Module 3. We have a lot to cover, so without further delay, I welcome Kim Newland.
Thank you, Teresa, and thank you everybody for taking some time in your afternoon to join us today for the webinar. So as Teresa mentioned, selecting a cardiac rehab champion is a vital first step in the implementation process. So who is going to be your team leader? It may be you or it may be somebody else. You really need to consider who the right person is to serve as the champion in your hospital. And this champion needs to be an individual who can disseminate the message about the value of both cardiac rehab as well as the value of the automatic referral with care coordination. This individual must have proven leadership skills, credibility in the hospital, someone who can help problem solve challenges as they arise. And that champion must motivate and provide momentum while advocating for the needs of the team, remove barriers, and build a culture to support the change. They also will be assisting the team in developing its aim statement and action plan. So further qualities to consider when selecting a cardiac rehab champion include someone who has credibility with the peers, must be passionate and interested in improving cardiac rehab, which I'm sure is everybody on this phone, otherwise you wouldn't be part of this group. I think it's really important that that person understands the cardiac rehab programs, structure, kind of the varying structures that are out there and allowed, and regulations, because those are very important, especially as you're developing that automatic referral process. Obviously, somebody who's going to be a champion has to be action-oriented. It's really helpful if they have experience with change management and improvement projects. And then, of course, as with everything, important is communication skills. All right, so then you need to think about who is going to be on that multidisciplinary improvement team. So as you consider forming your implementation team, think broadly about the staff members who will be needed to implement automatic referral with care coordination, those who represent all aspects of the cardiac rehab referral, enrollment, and participation process. So when you start thinking about it, it's actually a pretty broad spectrum of people from the inpatient side to the outpatient side. Physicians are key members because they care for eligible patients and drive referrals, as are nurses, hospital administrators, and managers. Some of you might have an inpatient or an outpatient cardiac rehab program that are part of your hospital, so you'll need to plan for that coordination across the inpatient and the outpatient programs. And if your hospital doesn't have a cardiac program, or even if you do, you often refer to other programs outside of your hospital. So especially if you have patients coming in from outside of your geographic area, you need to figure out who you can send to from your hospital. So consider how to make that bridge between the inpatient and the outpatient services. You may also want to think about including billing and insurance personnel to share insights about maximizing reimbursement. We did this a few years ago, and that has helped us immensely in just ensuring we have the right people in the referral buckets, as well as all the billing ends through the electronic healthcare record. And finally, consider including staff or even a patient advisor who could provide information about the needs of the patient. So I know some programs that have changed the names of their programs because their name didn't necessarily represent what the patients and their advisors felt should be for patients to attend, which can often be a barrier. So here, the next two slides have a list of different people to consider. And again, don't feel overwhelmed by the list of people. You don't need to include everybody, but just start thinking about maybe who the core group can be, and then you can expand on that core group, and you'll realize as you start to build your action plan and figure out the different tasks you need to develop that you will, you'll see that you have different opportunities to include different people along the way. So a cardiac rehab champion, like we talked about, who will lead the team and advocate for the initiative. Different clinicians, so cardiologists, surgeons, physician assistants, or nurse practitioners often are the ones who are helping make that referral or having that conversation with the patient to make sure that they want to be, to make sure that the patient understands that they support this program. Also the clinicians, so the ones doing the work, and it varies between programs. So nurses, physical therapists, exercise physiologists, as well as physicians can provide those valuable perspectives on enrollment and participation. And different cardiac care managers, they also can provide information about workflow. So it may be managers over your inpatient cardiac units or the managers over your cardiac rehab program, or even those who are managing the outpatient clinics where referrals may be occurring. I really think it's important to think about, if we're talking about an automatic referral through an electronic health record, is how do you bring in those IT staff, that information technology staff? They will really be able to tell you what is possible and not possible. It may be an IT vendor representative, but they can help not only with the referral process, but also data collection. And then if your cardiac rehab champion doesn't have a strong background in change management or process improvement, think about if you have lean coaches or somebody who's done a lot of process improvement who can help you organize kind of that strategic map and your aim statement and the things we'll talk about. But it's really good to have somebody, and even if you can get somebody from outside of your program, they may also bring insights that have worked well with other programs, so you can kind of get a double bonus with that person. And then, of course, again, I always recommend patients or a patient family representative, because those are the people who will tell you kind of what works or doesn't work based on the people we're building these programs for. Really, they tend to be our customers. So think about how to bring them in. Your hospital or system may have patient family advisors or counsels, so explore that as an option. All right, so now I'm going to turn the presentation over to Kate, who's going to share her insights about selecting a cardiac rehab champion based on implementing automatic referral at Mass General Hospital's cardiac rehab program.
Thank you, Kim, and to all of you who are listening and participating in today's webinar. I'm hoping that these real-world examples will be of some help to you as you begin to think about your own strategies and efforts in implementing automatic referral with care coordination. So although the cardiac rehab champion does not need to be a physician, we did find at Mass General that having one physician identified as a champion or as an assistant in the work of advocating for the automatic referral with their peers in particular was effective. So that physician at a staff meeting and via email, and I would just suggest that whatever process is internal to your setting that would be most effective would be the way for that physician to help you deliver the message. And the message should include, obviously, the evidence-based research data as to why referral to cardiac rehab is so important. And it can also include in the communication a picture of what your actual automatic referral looks like. This is a very important and a very effective peer-to-peer strategy that will add credibility to this process, as well as practical information for physician peers on the how to refer. You know, in tandem with this, it's important to remember, and I'm certain that all of you are well aware of the fact that there's a circle of people that support physicians in their work. And so to communicate out to those important staff members is essential. So that will include, obviously, the cardiologist, administrative assistants, and other staff members such as medical assistants and nurses. They'll be the ones that will be responding to patients' questions about cardiac rehabilitation and referral to cardiac rehabilitation. So they'll need to know who the cardiac rehab champion is, have some familiarity with the process, so that they'll be able to advocate and communicate effectively and correctly, giving accurate information. So in other words, there's really no such thing as too much communication when it comes to speaking about this. The one thing that I want to point out is that the picture on this slide is not meant to suggest that your team needs to be very large, but rather an example of the fact that reaching out to a larger community is really important and going to be something that you want to keep in mind as you get started. And lastly, one other practical tip that I'll offer is that the cardiac rehab champion really needs to be familiar with the structure of the automatic referral and how that referral is actually worked or handled by staff members. And one example from our setting is that because we are a tertiary care center, many of the patients that come through our hospital are referred out to hospitals or other programs outside of our facility because they're geographically more convenient for them. So we do have an option internally where a physician can refer to an external cardiac rehab program, and we learned early on that that those external communications or referrals to external programs were not directly directed to any one individual. So we quickly corrected that so that we were certain that we could work and help those patients get to other programs that would be more convenient for them. This slide represents, and this is just one more example of other resources that are available to you. This is an actual screenshot from the cardiac rehab change package of Table 1. And in Table 1, you'll find links to more specific ideas, tools, and resources that you can use to help with your implementation process. Kim?
All right, thanks, Kate. I didn't mean to advance your slide there before you were finished talking, and I was getting excited about what you were talking about because I think we had a similar an experience recently where we had automatic referrals coming in and then they stopped, and really we have kind of an informal champion in our referrals coordinator, and she was the one who identified and really had the conversation, and we'd had an epic upgrade that created a glitch in our referrals, so they were getting held up on the other end. So it was really a great win when you have your team and you kind of have a feedback loop, and you have champions and then some informal champions who understand the process, because that referral process and the work queue, it becomes pretty unique, and you have to learn how to navigate it. So thank you, Kate, for sharing, and we look forward to hearing from you later when we have some more questions. All right, so then when we look at planning for change and how will you get started, there is a framework that's been used a lot in healthcare, and it's the Model for Improvement, and it was developed by the Institute for Healthcare Quality. So many of you may be familiar with this framework, and it really starts with three fundamental questions. So what are we trying to accomplish? How will we know what a change is an improvement, or that a change is an improvement? And then what change can we make that will result in improvement? So, you're part of this group because we feel that, or we know that, a TAKEheart change and improvement will lead to automatic referral with care coordination. So that answers question number 3. And really, when we look at what we're trying to accomplish and kind of how we're going to do that, that really leads us to saying we need to develop an aim statement and then an action plan. So today we'll walk you through how to develop them, and then your coaches and facilitators for your partner hospital peer action groups will provide additional support. Obviously, we'll have some time for questions at the end as well, which we'll field those. But then again, when you start working on it, I'm sure you'll have more questions, and then you'll get some help there. Okay, so these are high-level steps required to developing an action plan, and we'll walk through each of them. So developing the aim statement. Step 2, determine how to assess or measure your progress. And then step 3, identify the tasks required to achieve the aim, who is responsible for each task, and that time frame for completing each task. So when we talk about developing an aim statement, why create one? And I think it's really important as you get into a big project which has multiple tasks or milestones, if you can go back to the aim statement and kind of the why, I think it really helps everybody on the team refocus if you get a little distracted, but also it's a lot of work. And so being able to go back and say, okay, what is our purpose and why are we doing this? Ultimately it's to help more patients, but by doing this step with the automatic referral with care coordination, you'll get more patients in your program. You absolutely will. So that's, I think, bringing it back to the patient, developing that aim statement helps everybody just, if there's a little wind out of the sails, it kind of can help put it back in. So it's that shared vision for the future, kind of what you hope to achieve, what we're trying to accomplish, and it's the first question in the IHA model for improvement. It should be clear and specific, really explicit, and that, but know that the statement can be revised. So you can have a statement for the first 6 months, and then you may get back to one of your meetings in 6 months and say, goodness, we need to really change this, and it's not quite the aim statement, or it may have changed just depending on what barriers you come across or what changes within your system or within your program. So the aim statement answers many important questions that drive the future of the project. Again, what do you hope to accomplish? Increasing referrals, enrollment, and participation. For whom? Patients with an eligible diagnosis. And for you, it may not be all eligible diagnoses. You may have a system in place, that really captures certain patients, like surgical patients, but you may need to then expand that to the medical patients or maybe the interventional cardiology patients. And then why is it important? As we know, cardiac rehab saves lives and reduces hospital readmissions. And then the change that we're going to implement in order to achieve that goal is the automatic referral with care coordination. So here's an example of an aim statement. We aim to increase the number of patients with MI, PCI, and CABG who are referred, enrolled, and participate in cardiac rehabilitation by 30%. This is important because we want to improve patient care and outcomes and reduce hospital readmissions. We will accomplish the same by implementing automatic referral with care coordination by December 31st, 2020. We intend to see a 30% increase in current participation rates by December 31st, 2021. So this aim statement, you can see, provides clear direction for the project and can be used to spread the message about the importance of the project. And you'll note that the date to implement the change is December 2020, and then the date by which participation rates are expected to reach their goal is a year later. Your aim statement may be similar to this, but each hospital will have its own aim statement. So how will you assess your progress? So you need to know if the things you are doing are making a difference. And it's really important to assess both in the short term and the long term. And I think, again, kind of part of why you have your aim statement is you can go back to that. But if your only assessment or measurement is a year out, you won't really know kind of how you're tracking, and you won't be able to give short-time real feedback to the people who are doing the work. Again, this isn't easy. We recognize that this takes a lot of work, and for the people doing the work each day or the people who are investing time and resources into the program, they're going to want feedback. They're going to want some data. So create some short-term goals. You can create the tracking mechanism, have the data, and share that, because I think that's important. One is to share the wins, but two, also to reset some of maybe your long-term targets based on how you're doing in the short-term ones. So developing specific outcomes and process measures is important. And so setting goals, setting specific goals that are numeric and measurable will help. And so that leads us into SMART goals. So you may have used SMART goals with your patients or maybe even yourself for changing behavior, but they work really well in process improvement. And that's because they help really define what the goal is. So specific, the description of a specific outcome or process. Measurable, how is it going to be measured, like rate or frequency of measurement. Achievable, so make it a stretch goal, again, but make sure it's achievable. Don't make it, we hear people when they're trying to lose weight, they say, I want to be at my high school weight. Well, maybe that's not always achievable. So maybe making it a stretch of a certain percentage, for weight loss, but maybe for you the same thing is thinking about how you're going to make that achievable. And then relevant, obviously, if the goal needs to link back to the aim statement, if you really are going to make sure that you have the best outcome possible. And then time bound. So you need clear start and finish dates. It helps everybody stay on track. And then if you're assessing and you're getting close to that time where you think you're going to finish and you need to kind of or fine tune that goal, you can do that as well. So here are a few examples. So the percentage of eligible patients referred to cardiac rehab will increase by 10% from first quarter to third quarter. The percentage of referred patients who enroll in a cardiac rehab program will increase by 5% from first quarter to second quarter, or the percentage of enrolled patients who complete a cardiac rehab program will increase by 15% from second quarter to fourth quarter. And again, once you accomplish some short-term goals, these can be used to spread the message of success and then again motivate the continued efforts to improve. All right, so then the model for improvement calls for developing the aim statement and the action plan. So now you have your aim statement, or you will, and then it will be time to operationalize the project. So now we'll talk to you about that framework for developing an action plan. Each hospital will need to create an action plan based on your unique situation, and then you'll work on that individually, and then also receive support and feedback from your partner hospital peer action groups. So the action plan components include tasks, responsibilities, and target completion dates. So this is where you need to decide the tasks that you need, because each hospital will have different things that need to be completed for you to take on the automatic referral and complete the automatic referral for care coordination. So as you look at the tasks, consider who will be responsible, set that target date for completion of each one, and some of those tasks might be very quick to accomplish and others might take some time. So as you put together your plan, remember to consider the resource needs and those priorities. So are there certain features in the electronic health record that need to be added? Do you need additional people at the table? And then establishing those priorities will help you then determine that timeline. So here is an example of an action plan template, and this will be provided to each partner hospital team. It actually has drop-down menus and free text boxes to help you fill in the table. So it'll actually provide you with some pre-filled areas, which will help you as you're developing your tasks. And again, these all come from the cardiac rehab change package, especially the milestones. So we're using the evidence-based data from all the experienced clinicians from across the country to give you different ideas. They may not all be relevant to you, but they'll help you kind of think about the bigger goal, and then you'll be able to identify the smaller tasks. So break down each task and assign somebody to oversee that task. And if they take less time or more time than planned, you can adjust that action plan so you can see that target date, and of course you can go in and adjust it. So again, going back to those milestones. So milestones are really high-level tasks, and these have been shown and vetted at other successful hospitals who were able to improve patients' access to and participation in cardiac rehab. We think it's important, we do strongly recommend that you include milestones and then the smaller tasks that will help you accomplish those milestones. So an example might be a milestone included in the cardiac rehab change package is include referral to cardiac rehab in order sets. Well, that's a milestone. I mean, that's not necessarily a task. There are going to be several smaller tasks that you have to do in order to get to that place. And these milestones are identified as critically important to success, and then achieving them will help you make progress in implementing the automatic referral with care coordination. You may have achieved some of these milestones already, so they may not be relevant to your hospital, but they can help you define, again, those additional tasks required to be successful. And again, thinking about those SMART goals and using the really specific criteria will help you. So here's an example of a task. So if we're looking to define automatic referral and what that means. So beginning on 2/4/2020, the cardiac rehab QI team will meet with IT representatives each Tuesday and Thursday at noon for half an hour to define the changes necessary for automatic referral, and will complete the task by 2/28/2020. So I apologize that we put the date for tomorrow. I just read that and I got a little anxious, like I hadn't completed the task. But you can see that's a good example because it has, when it's going to start, when it's going to end, how frequently you're going to meet. It's very specific. And then that cadence that you're going to be meeting is every Tuesday, Thursday, what the discussion will be. It's only going to be a half an hour. It's not a long, drawn-out meeting. Not everybody has that time, but everybody on the team will know who will really need to be there and what's going to happen and when to expect that to be completed, so then you can move on and plan that next step. So here is what it looks like in the action plan. So there's your task and your milestone listed in the left side of the column, who the lead is, the target date, the completion date, so when it's completed, the status, the SMART goal, and then any comments. So really putting in here what the barriers are, kind of challenges, or what's helping you get it going sooner, and that will help make sure you keep track. So if that task lead makes sure that comment is in there, you can quickly go back and say, okay, why were we delayed on that, or what is the barrier, and then maybe even kind of who can help remove that barrier, and who can the cardiac rehab champion really go to figure out if it's going to happen or not. I know when we started this process, we went to our IT team, and they were planning a whole new rollout of Epic. Like, we had a downtime, and it was a whole entire system process. And when we went and asked for this automatic referral, it was kind of a big fat no at this time. Not forever, but just we need 6 months. We cannot even focus on that. So that obviously put a delay in, but by having that conversation, we then knew we would have to wait until a certain time before they would even be able to allocate an IT expert to help us with that process. Okay, so then when looking at what's next, so the partner hospital peer action groups, they're there to support you, the TAKEheart partner hospital, through the planning and implementation of the automatic referral with care coordination. They enable staff from the TAKEheart partner hospitals to interact with each other, so you'll be able to interact with one another and looking at and discussing each of the monthly modules, share your experiences, obtain support and suggestions from peers, right? There's nothing like this kind of built-in support group to figure out if it's not working here, how is it working somewhere else? And especially when you're living the change and trying to figure out process improvement, it's nice to have people to bounce ideas off, especially from outside of your facility. So at your next peer action group meeting, you'll discuss how you're proceeding on developing an action plan. You'll exchange your action plan with another hospital, and you'll give each other feedback. So you'll be partnered up and be able to give each other real-life feedback, and those coaches will be able to help you. So Teresa, now I turn it back over to you.
Thank you, Kim and Kate. Well done, and you gave us so much information um, to consider. So thank you for sharing your insights. Before we open up the room to questions for our speakers, I want to provide a preview of the next module. So next month, we will continue to focus on building the foundation for systems change by examining workflows, processes, data capture, and analysis. We will dive into the details of that cardiac rehab process with looking at referrals, enrollment, and participation. And we will discuss a little bit about what data you will want to capture and use for implementation. So we encourage you to join us next month as we continue to support you on the journey to automatic referral with care coordination. Now we would like to hear from you. At the bottom of your screen, you will see a conversation bubble similar to the one pictured here on the slide. Clicking on that bubble will open up a chat box. Please set the to field to all panelists. This ensures that we can all see your question. And we ask that you keep your questions general in nature and not hospital specific. That way the entire audience can benefit from the question. We may not get to all of your questions today, but we will respond to unanswered questions after today's event. So feel free to type in your questions in the chat box. Our panelists are ready. And we have our first question. And this one is for Kate. Can you tell us about a hurdle that you faced in the transition to automatic referral and how you overcame it?
So thank you, Teresa. I don't know where to begin with this. There are always going to be hurdles and challenges along the way. I think what I'd like everybody to know is I hope and expect that you will see a large increase in the referrals to cardiac rehabilitation. And along with that, it represents really the enthusiasm of the physicians and some of the hospital staff and outpatient staff, cardiology staff, in getting patients to these evidence-based programs. But in doing that, many times we found that a number of the referrals that we received were on patients that didn't necessarily meet their insurance eligibility criteria. So I think that the most important tip for you is that whoever is receiving the referrals or going to process and work those referrals needs to be abundantly clear with the cardiac rehab program regulations and coverage criteria, and needs to quickly look through each of those referrals to be certain that the patient is eligible for the program. So the other consideration I think that you might have, and this sort of harkens back to Kim's, the very end of the presentation when Kim spoke about action plans, and as you're thinking about creating your automatic referral, you may want to consider building into that some tips or directions to the person completing the referral as to who those eligible patients are. So you may want to add, patients who've had heart attack within, the certain time frame that they need to be within, PCI, if it's a heart failure referral, that they meet the ejection fraction criteria. So those are the kinds of tasks that you might want to think about as you're going through the development of the actual automatic referral. And again, it's just to remind you to remain vigilant that, all referrals will not necessarily be all comers, and you just quickly have to be certain that those patients truly are eligible.
Yeah, and I think, this is Kim, and I would just kind of piggyback on that is developing a feedback loop. And that was when we really started this process. We were looking at low referral rates. We had some frank discussions with our cardiologists. Like, we did a survey and we said, why aren't you referring? And they, one of the top things was we don't know what happens to our referrals once they get over there. So that feedback loop back to them is so important. Just, if this patient doesn't qualify, why? So no, mitral regurgitation isn't a qualifying diagnosis, or diastolic dysfunction, especially when heart failure came out, right? Of course, those patients, we'd love to take them in with an EF of 65 with diastolic heart failure, but we can't at this time. Hopefully in the next few years that will change. But really that feedback loop, and so we developed a staff message kind of process back to the ordering physician, at least those through our electronic health record. And I think that helped in that education. So it didn't feel like they went into a hole. And then we also, in our referral, in our electronic referral piece, we put in a note so anybody could go back in and look at the note. And so if they got a call from the patient, they could explain. So we call the patient, we send a message back to the clinician who ordered it, and then put a note in so we could all speak to it and be consistent with that message.
Great. Thank you both. We have another question. Somebody has been told by the IT in their hospital that their EMR will not support an automatic referral. Have either of you encountered a barrier like this?
So the EMR, or is it the team? Maybe a clarifying question is it the team when support, like I had mentioned, we didn't have somebody to support. So a question back would be, what electronic health record or electronic medical record do you have? We currently use Epic, which does support it, but it was supported through local help in building out smart phrases and building out the referral so it had the right information in there. It sounds like this person uses Cerner. So Kate, do you have any experience with Cerner?
You know, I don't have any direct experience with Cerner, but there are other ways to alert providers to patients who may be eligible for referral to cardiac rehabilitation, separate from an automatic referral process. And those are things that might be called best practice alerts, so that if somebody is charting or documenting on a patient that meets eligibility criteria, in the background there can be some logic built in that would have this pop-up alert that would suggest to the provider that this patient may be eligible for outpatient cardiac rehabilitation, and therefore you might want to consider a referral. So I would suggest that you speak with your IT people. This is why it's so essential to have them as part of your team, that your cardiac rehab champion find those IT specialists, bring them aboard, and then talk with them. If automatic referral is challenging, which honestly I'm not understanding why that would be, but assuming it is, that there are other avenues such as these best practice alerts that can be built in that would draw somebody's awareness to that automatic or that referral eligibility process.
And I'm seeing some messages come in. So it looks like somebody said they work at a hospital that uses Cerner and they have automatic referrals, that it's possible. And someone else chimed in that you can add them as a bundle protocol for cardiac events on Cerner. So for those of you in Cerner, hopefully you know what that means. I don't exactly know. But Kate, true to your point, is if it's not possible, there are other processes, or it may not be necessarily that automatic referral, but some way to alert or flag the patient in the system. So how do you pull them from a DRG or an ICD-10 code or something, right, that then can create this alert?
Absolutely, and I am also seeing some comments about whether the package that a particular hospital purchases when in relation to their referrals or their electronic system. There is, for most of these large electronic medical records, a library that they may be able to look to help answer some of the questions that you will have. And that is that they can truly go to a catalog of sorts to look through what other institutions have done in certain circumstances to help achieve whatever end it is that you're seeking. So if automatic referral is challenging, again, I would work with the EMR staff themselves along with your IT staff to see what other institutions using that particular system have put in place to help address the problem.
I see another question about automatic referrals to outside facilities. I think, Kate, you talked a little bit about that earlier.
I did, and so, certainly we don't want anybody who's eligible for cardiac rehab to miss that opportunity. So what I would suggest is that your cardiac rehab champion and team would set up a system so that those patients are still identified and referred, but that somebody internally would then work with that patient to help them, find a program that was close to home, and then facilitate transfer of information from your facility to that outside facility so that the patient has that kind of warm handoff from one institution to the other.
Great. And from the patient perspective, to what degree have you also educated patients that they have been automatically referred?
This is an excellent question.
It is.
And the reason I say that is because It's so important when you pick up that phone or have that reach out to the patient, whether it's a face-to-face visit or a telephone call. It's so essential that the person understand where that came from. You are probably not going to be necessarily a familiar face to that patient. You may not have been part of their care process to this point. And so you have to establish immediate credibility with them. So I will often open the conversation with the patient by saying that the cardiology team or your cardiologist or the physicians that recently took care of you have communicated with me and asked me to reach out to you to talk about cardiac rehabilitation. So that automatically sets a tone that you've been in touch with their personal physicians or physician team, and that it was at their behest that you are being, that I'm reaching out and looking to talk with you about this. Kim, I don't know if you have any other thoughts or ideas.
Yeah, so we created a handout. So those who we use cardiovascular coordinators. We don't have a true phase 1 cardiac rehab program at the facility I'm at. So we've used some kind of navigator coordinators who provide a handout to the patients, and it has the signature of our medical director, and then we talk about in the letter we talk about what it is, because I think there's a lot of misconception around, I mean, they hear rehab, they may think physical therapy, they may think different things, and so that the letter reinforces it because they're getting, a whole armload of patient education materials and information when they're leaving the hospital. And so we use those. We shared them with our primary cardiology referring office, and we shared them with our primary surgical hospital that sends them to us. So another bigger facility does our cardiac bypass surgeries and valves and sends them to us. So they can get that information about our program. And it really says on there, if you have not heard from us, call us, because something could have happened to your referral. So we find that, the squeaky wheel, the squeaky wheel gets the grease, and so we say that, call us if you haven't heard, because our goal is to get back to you within, a few days of getting that referral. So that's one way that we educate them so they know they've been referred. And then, again, what our clinicians are saying is really emphasizing that, every people who have, we talk about how the level of recommendation, so similar to an aspirin, you're being recommended cardiac rehab and how it helps with morbidity, mortality, and preventing readmissions, but obviously not in those words for patients. As far as patients going back and talking to clinicians, we haven't had that, but we do hear back from the clinicians about how happy people are with the program, and we hear when they haven't been referred. So that's what also helps us identify if there's a glitch in the system. But it's obvious they keep referring, and they're referring more and more. So then we're obviously doing something right.
Have either of you gotten feedback from your providers since implementing automatic referral? They like it, or any feedback you've gotten from them?
Ours has been good, and it hasn't slowed down any sort of business. Obviously, it shouldn't, but we've just heard positive feedback once we kind of worked through. But that was also part of keeping them invested in the beginning and kind of what their needs were.
I would agree with that, Kim. It's very easy for clinicians to be able to check in the box or make the automatic referral. And because we're getting the referrals more quickly, we're able to reach out to the patients more quickly, and that's essential in terms of getting patients into programs quickly. So I think that they've appreciated that the process has really been hastened by this automatic referral, and have appreciated that more of their patients are able to take advantage of the programs. I did see a question, I think, that just flashed up about seeing the letter. I think, Kim, maybe that was the letter that you were referring to that you're sending out or using. With patients, and I also just want to mention to everybody that, again, the Cardiac Rehabilitation Change Package has some great tools and resources that may be of some help to you in this regard as well.
Yeah, no, great point. Absolutely.
Any other questions out there? Our panelists are ready to answer your questions.
or do you guys have any comments about what you have in place, or can anyone share some learnings that we can kind of report out to the group about things that have worked or have definitely not worked?
So I just want to tell everybody that these questions are really very good ones, and it indicates to me that you're really thinking and, have a real good feel for what some of the challenges will be in your area. And I think that, first of all, trying to anticipate those kinds of things is going to make your processes even better and allow you to be more successful right from the get-go. So, congratulations on being so forward-thinking and kind of cognizant of where some of the challenges and barriers might be. This automatic referral has actually added a large volume of patients to the program. So I know that in some of the future webinars, there'll be more discussions about enrollment and adherence. And, really important for you to begin thinking about or include your cardiac rehab professionals and team to start thinking about how to absorb some of that increased volume, because I think that, that's really the end game here. That's really the point and the expectation. And, automatic referral is the first step, but then, it's a funnel. You don't want it to narrow down too much so that there's a backup in terms of getting patients through and into programs. So the more that, your teams can begin to think about some of those things and, listen into some of the future modules that'll be forthcoming, I think will be of real importance as well.
Yeah, and, I think we are in a very small site, and since 2015, when I took over, we had 3 classes on a Monday, Wednesday, Friday, and now we're currently at 5 classes on Monday, Wednesday, Friday, and 3 to 4 classes on Tuesday, Thursday. We just backed off. Beginning of the year, I'm not sure if all of you feel it, but we feel the deductibles aren't met. The copays are a little bit prohibitive. I see a question about copays as well. But for those of you who are experiencing that growth problem, we actually have approval and we'll be moving to a space that's more than 3 times the size we're in now because we expanded our programs so much, and there was so much positive feedback from the community and the people who've attended, and our outcomes and readmission rates for acute MI patients especially has really dropped significantly. There's a question in there about, is the automatic referral order being placed at discharge or sooner? So technically how ours work, it can't be an inpatient order because an inpatient referral for us doesn't go. So ours actually hit the bucket when they're being discharged. You can put it in when they're on the inpatient side, but it's a discharge order. So it goes to an outpatient referral process. I don't know, Kate, how yours is built.
So our referral is built into the discharge orders as well. Although while patients are still hospitalized, we can receive some of those referrals, but typically once the discharge is complete and the documentation is complete, the referral then is processed out. But we do also receive referrals from outpatient settings. So when physicians are seeing patients in clinic after discharge or just in follow-up, there is the ability for them as well to utilize the referral process, the automatic referral, or a electronic referral process to send those referrals as well.
Yeah.
I see a question about successfully increasing the use of cardiac rehab beyond capacity. Do either of you have ideas or solutions to help manage the patient backlog?
So as we were growing, I had a fantastic boss who was guiding me through this, and his question was, are you really full? Like, are you really at capacity? And I kept looking at him going, yes, but no. So that was when we moved to a Monday, Wednesday, Friday to a 5-day-a-week model. So some people want to come 2 days a week. Some, especially with our heart failure patients, they like to come. So we changed. We increased our staff. We started offering 5 p.m. classes. We hadn't historically had them. So my question back to you is, are you really at capacity? I know it means you'll have to increase staff, but if you have a target like units of service to volume of, or to staff ratio or something out there that's your target, if you are staying with your target and you're meeting kind of how many patient hours versus how many staff hours, then usually that you should be able to build the business case. But I think as you go forward and you start having that conversation with key parts of your team and you're engaging administration and you're talking to your physician champion or your medical director, hopefully that's the problem that you have, but you need to start talking about it now. So what if we do have too many people? How do we quickly mobilize teams? So for us, it was hiring per diem staff so that we could flex up quickly if we needed to, or kind of anticipation. So we had some per diem people who were able to then, when we added a 5 o'clock class on Monday, Wednesday, and then when we added a second 5 o'clock class, we had staff who were willing to take that on.
I also want to just, again, point everybody to the Million Hearts AACVPR Cardiac Rehab Change Package. You know, a number of the tables in the section on enrollment and participation address the concepts that were brought up in that question around, you know, how to actually structure your program or be responsive to increased volume and demand. And you know, it'd be terrific to think that you'd get more resources, more physical resources, more human resources to help with some of this increased volume, but that won't necessarily happen right away. So some of the change concepts in the change package are going to be very useful to you if you come up against some of those challenges. So developing flexibility to help accommodate more patients and their needs, modifying perhaps some of your program procedures based on clinical need, you know, such as the use of ECG monitoring or the taking of blood pressures throughout the course of the program, thinking about changing your schedule, having more of an open gym concept. I mean, all of these are the ideas and the resources that exist in the cardiac rehab change package that I think will speak right to some of those questions and issues that you're concerned about, and rightfully so.
I see a question about cardiac rehab programs also having pulmonary rehab programs in the same space. Comment about that.
I know we do here, and I think from kind of across the Sutter system, we have eight cardiac rehab programs, and I think 6 share space. So most do, and it kind of makes sense. And we've actually started sharing resources some as well. We don't currently live under the same cost center, but it allows us to be flexible. So Kate mentioned, how do you have a flexible staff? So exercise physiologists are now cross-trained in pulmonary rehab instead of just cardiac rehab, which hasn't historically been the case. So they can provide a consistency while we have nurses and respiratory therapists kind of rotating out and doing the initial evaluations.
I think it's really an excellent topic for you to bring up in your partner hospital peer group meetings and discussions, because I think that learning from each other is probably one of the most effective ways to do those idea sharings and come up with some creative strategies. And it isn't just about, you know, pulmonary rehabilitation, but, you know, there are other programs that within your cardiac rehabilitation program you might want to think about adding and including. And so, you know, sharing those ideas and working, you know, with your peers across the country or in your area, you know, as you meet together, can really be fruitful in helping you think and hear about some ideas that maybe hadn't, you know, occurred to you.
Well, great. I know we want to be mindful of people's time today, and we have a couple of questions that we would like some feedback on. So I want to really thank everyone for coming today, and for our speakers, Kathleen Trainer and Kim Newland. We appreciate all of your insights today.
Thank you for having us.
Yes, thank you.